we have a co-authorship system where anyone who submits data is citable on PubMed. And Integrate has a structure whereby there's a central committee that's got a chair and a secretary. The secretary's central to it at the moment, and that's the fellow, which is John's position, and that's currently funded. And then there are 3 subcommittees, and they're the otology, rhinology, and head and neck. And so you can choose somewhere that's relevant to your interests. So it wasn't our idea to do a research collaborative. It's something that had been established several years before, and the West Midlands general surgeons were the real pioneers with this. And after their initial steps, they developed a trial, and they published a randomized controlled trial in the BMJ. Everyone thought it was, you know, a really good example of a trial, let alone done by some trainees with the aid of a clinical trials unit. And that spurred off a lot of other people around the country to do their bit. And in ENT, we had lots of regional collaboratives spring up, one of which generated the multi-centre audit of Quincy's, which was quite relevant to what we're going to be talking about today. So then Integrate came along in 2015. We met at the end of the year at the Royal College of Surgeons, and not long afterwards we launched the Epistaxis audit. So that took place in the latter half of 2016, and we published data the year after. We recruited over 100 sites, and a lot of the data is very relevant to what we found during COVID, and we'll talk through that as we go through this talk. We then turned our attention to head and neck follow-up, conducted an audit with Barno, recruited common trainee-led management condition. But what we found is that we don't really know how to measure if it works, and we don't really know how to diagnose it. So we developed a core outcome set and diagnostic criteria, and they're under peer review. We also looked to develop an Epistaxis randomized controlled trial in the rhinology group, and the tonsillitis quality of life study was a prospective study the head and neck group were working on. And then all of a sudden along came COVID, and it had a real impact on research that everyone was doing. Even very well established, very well funded trials had trouble dealing with COVID. And we found that people were redeployed, people's focuses shift, and we didn't really have the ability to interact with outside groups that were dealing with COVID. So we had to do something different. And so that's how the emergency care audits came about. And I don't need to tell you what COVID is. I'm not going to tell you what it's done to the health system, but we all had to make lots of changes to protect patients and staff. And of course, we had to maintain the hospital bed capacity. And that provided particular challenges to ENT emergency care, just as it did for other specialties with their emergency care. We introduced new, very untested practices, often practices with limited or no evidence in the UK, and things that we hadn't done previously. And this came at a time of strain on services, lots of redeployment, and also on clinicians. We were doing things that we wouldn't normally do. We had our day-to-day structures changed. We had members of the team stripped away. And there was, of course, this considerable concern over aerosol generating procedures, particularly at the start. And that's something that ENT UK has been very supportive with. But with a lot of emergency care, using endoscopes, dealing with nosebleeds, there's a lot of risk for aerosol generation. And finally, we also removed the normal team structures, the normal hierarchical levels where you've always got someone you can ask. And we removed some of the clinical governance. Regular audit meetings went out the window. Things that happened over Zoom weren't quite as effective. So there was a risk that things could fall through the cracks a bit. But there are also some opportunities to improve patient care, both at the time of COVID and beyond it. So there was an immediate unified change in practice across the UK, which is almost impossible to generate in any other way. It's almost unheard of. And there was also this very significant shift in clinician and patient priorities. All of a sudden, clinicians were trying to be very streamlined with their examination, trying to reduce risk of virus transmission, and trying to preserve in-hospital capacity. Things that we did before, but wasn't quite so stressed. And patient priorities changed as well. Patients really didn't want to come to hospital, and they definitely didn't want to be admitted. So there was a quite significant change at the time that had several outcomes. So which conditions to study? Well, we wanted something that was common, partly because we could therefore collect a lot of data, but also because it would therefore have a big effect on patient care, to affect the greatest number of patients if we found that there were problems arising. We wanted something that was trainee-led, because that's what we're best suited to collect data for, and something where there'd been an altered practice that requires an evaluation of outcomes. And importantly, we also had some historical data for quinsys and epistaxis, not quite for tonsillitis, but that was really useful in deciding, therefore, that epistaxis, tonsillitis, and quinsy would be our target topics. And ENT UK endorsed guidelines that have been generated for both of these and published them at the very start, or the very end of March. So this is the ENT UK Epistaxis Management Guideline. A lot of it is very familiar to us. A lot of it is very similar to what we've been doing pre-COVID. However, there are some significant differences once you've got past the PPE. There's the insertion of a unilateral bioresorbable dressing. That's what we call a dissolvable dressing for a lot of this talk. And that's things like Nasopore and Flow-Seal. And they weren't used very much at all in the 2016 national audit. And the reason being because that we want to use them now during COVID. They don't need to be taken out. The patient can be seen once. It's much more straightforward. And the second change was a movement towards discharge. Now, there's always been an idea that you discharge patients with a dissolvable pack, but this guideline introduced to the UK the idea that you discharge a patient with a non-dissolvable pack, and then you see them the next day or even the day after and take it out. Moving on to the tonsillitis and quinsy guidelines, again, much of this is very familiar, but there was an enhanced emphasis on discharging the patient and what you could do in A&E to try and make that patient suitable for discharge. So here, if the patient wasn't able to swallow and wasn't therefore safe to go home and keep hydrated, you gave them stat antibiotics, you gave them stat steroids, gave them some fluids in A&E, some analgesia. And then you reassess them several hours later. You know, some of us are doing this already. It's not groundbreaking stuff, but it was something that isn't widespread and was emphasized as the core of this guideline. So at the start of April, whilst sitting on a medical ward redeployed, John and I have been discussing options, and I sent a group to the WhatsApp, sent a message to the Integrate WhatsApp group suggesting we looked at these topics. John, primed and characteristically enthusiastic, replied. And the reason I put this here is because it shows the process of what you can do with a trainee collaborative. So we put together a data collection form, a Word document for the protocol, and then it went to a big Zoom meeting. And this was lots of different trainees who were part of Integrate, who just picked it all apart, looked at the protocol, what works, what doesn't work, what should our outcomes be, you know, what's important, what can we just put to one side. And the same goes for the data collection tool, because we found previously that if you've got a very big data collection tool, you get this huge data set, but it's really incomplete. So what you wanted is a data set that's very focused and it's going to tell you what you need to know, and not collecting data that isn't necessary, and possibly not collect the things that aren't really important, because if you ask too many questions, you just get nonsense back. And in parallel to this, we asked ENT UK if they would support the work and spoke to the guideline authors to see if they had any insight as to what we should be doing as well. And then the reason I've put this up, this is the advert that was on AOT. We also advertised via ENT UK mail shots and Integrate website. But you can see here that from the 1st of April, when it was put to the group, there was this big group effort. And then on the 6th of April, 8:25 AM, we could launch this project and start collecting data, you know, almost immediately. John's going to talk now about the methods, and then I'll take over again later.
I'm going to kick you off now, Matt. Hopefully everyone can hear me. Is that coming through okay? A nod from you, Matt, would be great. I'm going to assume that everything's okay. Right, yes. Let's see what we can do here. So we have to click delete. So a quick word about study design. Could Mood touched on that earlier, and how we're able to get multi-center data so quickly. So is it audit, is it research? Well, for the purposes of a local registration, it's an audit because that's the simplest thing to do, and it keeps your local clinical governance department happy. It means you get a code. It means that you've got a supervising consultant. It's something you can put through and present at your departmental meetings. But we want anonymized data submission centrally because that keeps your call guardian happy. You don't have to identify the site that it's coming from. You don't have to identify any patient dates of birth, names, hospital numbers, anything like that. But if it's proper research, it also would need a sponsoring trust to take overall responsibility for that. But to keep us happy, because we have no money, it's easier to put it down as an audit as well. So we don't have to pay the R&D staff to go chasing anything. And actually, the HRA provide a very useful tool to help you decide whether this is something that's audit or research. And they ask you 3 key questions. Is it randomized? No, we didn't randomize anything. Did we change standard practice? No, fortunately, COVID and the guidelines did that for us. And is it generalizable to a broader population? Well, by its design, we said, let's try and do something national. And we'll look at all comers of Epistaxis or tonsillitis and quinsy. So no, we weren't trying to apply this to a different group and study a smaller group. So in terms of the study design, the data collection, it was a national audit. In terms of what you do with that data afterwards, well, then it can segue and become a prospective observational cohort study if you want it to sound posh, because this is something where you're gathering a group of people, and then you're looking at an intervention, and you're looking at the outcomes of that intervention. So when it comes to publication, well, you can choose which hat you want to wear at that stage. In terms of registration and things, we decided that it was simplest to keep this just one protocol, one study methodology. It means you get one registration, but then we can be cheeky and divide things out afterwards until the data's come in. So what do we do? As Matt said, AOT and ENT UK helped us advertise. We were looking for anyone. We were not fussy. Anyone who would give us some data. We said, please get involved. We were looking for consecutive patients with acute tonsillitis, which wasn't traumatic, and because that's the same thing we did with the 2016 audit, and for any tonsillitis and PTAs. And again, hadn't done tonsillitis before, but it was on the guidelines that had just been released. So we thought, wow, yeah, let's spread our wings and collect some more data. And we were only looking at adults, just so we had a nice homogeneous group, and anyone that was referred into ENT secondary care and for tonsillitis. That was just from EDs. What do we do in terms of data collection? Well, to kind of satisfy everyone again, we have this Excel data tool model that we try and deploy, where you locally, I imagine most of you or a lot of you listening would have been involved at some stage, but if you weren't, then you have these Excel data tools which you can download off our website, and it allows you to enter data locally. You can keep that up to date. You can put anything you want on that. You can put hospital numbers, dates of birth, favorite color, anything you like from the patient. But then when you submit it, you strip all that information off. So you take away where it's come from and anything else that might be identifiable. It means you get this very tight spreadsheet where you can actually collect multiple things within one column, and then you can split it off later to create your W variables and do your analysis. But you can see like one box here allows you to say both whether it was suspected or confirmed, whether it's active or resolved, whether it was a diagnosis on clinical history or positive swabs. So it's nice and easy to enter that data. That's one click, but that's 3 little snippets of information which we can then divide off. And why do we do that? Well, look at this data completeness. So again, we had all of that time that was spent stripping this down to make sure it's just nice and core things we were looking for. Over 99% of our cases that we were looking at for the primary outcome were complete. We also set out a priority that we were going to do these interim reports. The idea of this was looking at safety and trying to rapidly feed that back to the ENT UK community, also the UK ENT community. And so we had these kind of 4 week intervals that we sort of decided that it would be useful to be able to kind of give that information back to people. And as you can see from the deadline submissions to the turnaround time for the report being released, again, the priority here was to get the data in, get it analysed, and get it out to you guys as soon as possible. And although that was much longer for the final report, that really was because you had to prepare all the manuscripts and get everything put together. And writing by collaborative is not the quickest, as you can imagine. Okay, so I'm not going to dwell on these, but these are the kind of stats that we had from the interim reports, but trying to get it graphical, trying to get it rapidly disseminated and back to you guys. If you haven't seen them already, they are on the website, or you can email me and I'll pick them up to you as well. And in terms of headline results, well, hopefully you'll be represented by a pin on the right-hand side if you did contribute some data, but we had representatives from all 4 nations in the UK. We had a really good number of cases submitted over that 12-week period from 83 centres. So, right, now here's a very intimidating slide, but this is one of the ones that's gone into the manuscript. So I'll digest this and then deconstruct it for you now. So we essentially had these 3 periods, and things came in pretty soon after lockdown, and still when the cases were on the rise. So we're adding there the UK COVID cases on a 7-day rolling average, and you can see how we picked that up from sort of the 6th of April when this was launched. Next, we're going to add in centres. We had 83 centres to add in, all but 2 of them were with us for the duration. And this shows the recruitment, or the as they came on board. So we said, as long as you're able to collect data and contribute data, we just wanted to know your start date, wanted to know your end date, and then we knew how to work out the cases and the rates and the averages and things that were coming in. Okay, so that's your background. That's the kind of national picture and how our data came in. And then we'll have a look at Epistaxis about the COVID swab rates. So again, we thought this would probably be something that people would very quickly move on from, and we'd be more interested in just, can we send patients home? But obviously we're now entering into this second wave, and all of this becomes much more relevant. But the top diamonds there are the proportion of people that have swabbed, so Epistaxis cases that came through. And as swabbing became more prevalent, we had more swabs available, the rates went up, and by the end of it, nearly half of our patients that were presenting to ED had a swab. The proportion of positive swabs was pretty low. It did drop over the period, but we think there's probably some selection bias in there, where it was only if you were kind of pretty symptomatic that you're going to get a swab. Where there's a high clinical suspicion initially, you probably get a swab, so it makes it look like there's a higher proportion. I mean, you can say that there was also a drop in the national prevalence, but really this isn't very common amongst this population, so you don't really need to be worried about COVID from our study findings, but Matt will touch on something else in a moment. We'll take away those labels and just pop in, these are the median cases that were seen per centre over those 3 periods as well. Again, at the beginning, fewer centres, bigger error bars, more variations, and by the end things are settled down. But we're having around 2 to 3 incidents of Epistaxis per centre that was contributing per week. So that's we'll talk about the context of that in a moment. Okay. Let's take them away, and then we'll add in the tonsillitis data. So this is again for COVID. You've got grade in the background there as your Epistaxis rates. But you can see from the diamonds there, a lot more of your patients that were coming through with tonsillitis or peritonsillar abscess were being swabbed. And that's probably because they just mimic COVID symptoms much more, and they're coming in with a sore throat. You'd be thinking, oh, maybe this is something a bit dodgy. Let's use one of our rare swabs on them. But the rates of positivity were, again, pretty low. You can see they're still just knocking around the bottom there, and pretty negligible amongst that population. And again, we didn't see really much in the way of variation of numbers of these cases coming through over that audit period. The error bars get more and more accurate as time goes on, and again, the Epistaxis data just ghosting in the background there to see. Okay, so let's look at Epistaxis specifically, and we're going to look at how these, well, about 90% of our cases were from the ED, and although we were very grateful for your data from the other centres, we couldn't really analyse it all together. We thought it'd be stronger to just look at the ED data. So I want to highlight a few things to you there. Intranasal management on the left-hand side. So these are the 4 categories we came up with. Nothing done to your nose, cautery only, a non-dissolvable pack, or a dissolvable product that was used. 3 things I want to highlight. Half of our patients are already packed by the time they get referred from ED, and that's even in this day and age, even when you don't want to touch these patients if they could potentially have had COVID. EDs do not use dissolvable products. They either did not get the ENT UK guidelines sent out, or they are not feeling sufficiently trained. But yeah, only 2% of patients. I mean, I had a fair stab at it, but not many of them are using dissolvable products. But ENT are using dissolvable products. So a third of patients had a dissolvable product used by ENT. But actually, you look at it the other way around. When you shoved something in the nose, if you were going to shove something in the nose and not do the cautery or nothing, then 61% of people had a dissolvable product used, and only around 40% had a pack used. So that's pretty good, and that shows that ENT's practice is certainly changing, but maybe our hands are tied by what's already happened in the ED before they got referred to us. And also just going to flag up that tranexamic acid use was pretty low, although recommended in this population, and still less than 1 in 5 people are having this drug used in an acute hemorrhage situation, with pretty good evidence to say that it's going to reduce blood loss, particularly in trauma and in surgery. So that's something that perhaps should increase, but that was higher than we saw in 2016. Right, another sexy graph. Again, one that's gone into the manuscript, but I will deconstruct it for you. What do we have? Okay, so Epistaxis patients, these people with nosebleeds. On the left, you've got what was done with the nose, and on the right, what actually happened to them in terms of admission and discharge status. So we look at their admission status first of all. You can look at the proportions of all these, and that gives you the representation of what happened to them. It's a patient flow thing called a Sankey. chart or Sankey diagram. And who are we discharging? Well, if you didn't have anything done to your nose, you have a pretty good chance of being discharged. We had about 15% social admissions, so they're split across everyone. So some people with nosebleeds are just going to get chucked into hospital regardless. If you're cauterized, we still 90% of people still managed to be discharged. That's pretty good. And if you had a dissolvable product, 71% of people were sent home as well. And we can't say that everyone should have had a dissolvable product used, or if you had a dissolvable product used, you will get 71% discharge. But just that from the data, with the people who we selected for dissolvable products, we had a 70% of them were able to be sent home. So that's pretty good. What about our non-dissolvables? So back in 2016, there were 520 people that were packed, and 0 of them were registered as being sent home with a pack in. So although that number there, 29.5%, is pretty low, being able to send nearly a third of our patients home with packs in is pretty encouraging, that we're going to start to see perhaps a shift in practice. And again, we can't say that all people with packs could be sent home or should be sent home, but we just saw that 30% of people were packed and sent home. Okay, let's move on. What happened to them afterwards? So if you admitted to hospital, you obviously had your index admission, and then we looked at whether you were represented after that. And about 10% of people ultimately came back into hospital even after they were discharged. And if you were originally discharged, so you never had an index admission, the admission rate was about 20%. I'm going to ignore the admitted for now, because we're more interested in these guys that we're trying to send home, because that's where the potential changes in practice will come. And we look at their representation status. So back over to the left-hand side, top left here, we see that those who represented, if you had nothing done to your nose or cautery, these aren't standout figures. They're not too different from that 19.5%. And even amongst those that were packed, you think they're probably going to have complications, or they're going to bleed, or the pack's going to dislodge. Unscheduled representations weren't significantly different to others in the group, and for our dissolvable guys as well. So most of these had no intention of seeing them again. They wouldn't have even been reviewed in clinic. We just kind of whack the stuff in and send them away. About 1 in 5 of them came back, but they've avoided that index admission. We did do some stats on it, but I don't want to dwell on that too much, because it's not too groundbreaking really. So if you didn't have a pack put in your nose, you're more likely to actually represent, and that may be because packs have some therapeutic benefit. That was certainly something suggested by our nasal packs paper we did, that it does give a tamponade effect, give you some ability to form a clot. So those on antiplatelets, or somebody had meddled with their nose but not achieved hemostasis, or if you'd had nosebleeds and already represented, then you're more likely to come back as well. Okay, so let's think about it a slightly different way. If you were originally discharged from the ED on your index presentation, well, obviously none of them were admitted, and 100% of those admitted went into hospital. The representation rates we've just seen as well previously, so 19.5 versus 9.5, excuse me. But if after you'd come back, 5.7% of those who originally had been admitted got a readmission, so they had that 100% plus the 5.7%. But the rate amongst those who were originally discharged was only 6.8%, so not significantly different. So they didn't have their index admission, and only around 1 in 17 of them actually ever got admitted into hospital. So we can't say again that we should be discharging everyone, just that those who were discharged seem to be discharged safely. And even if you represented with a problem, your chances were that you'd be sent away and avoid ever being admitted to hospital. So outpatient management of epistaxis seems to be pretty good. So rates, not too different from what we've seen in 2016. Probably because if you're bleeding out of your nose, there's not really much you can do. You probably can go to A&E. There's not really much you can do in terms of self-care at home. Non-dissolvable packs, what was the change in practice seen there? Well, we don't like them necessarily. We're sort of integrators taking a stance against them as much as we have a stance on anything. But a recent meta-analysis that we've submitted just looks at people's discomfort, whether they've had that dissolvable agent or a nasal pack used, and clearly patients are feeling that from this visual analog pain score, that packs are painful, dissolvable agents aren't. And actually, we asked 20 representative patients from 4 centres in the nasal pack success paper we did earlier this year, and our pack insertion. So the median pain on insertion was 8.5 out of 10, and even when in place was 5 out of 10. So patients don't like them going in, and they don't like them when they're in there. But it's so painful going in that if you ask them what they want to do, knowing that a pack being in place for 24 hours rather than coming out immediately in the ED will increase its success only by 10%. So the chance of needing any further cautery or repacking or anything like that only by 10%. Patients will still say, no, please just leave this in my nose, park me on the ward. I don't want you meddling with it again. I don't want to go through that experience of being packed again. So a move away from dissolvable packs will certainly be useful. Now, this is an image. I tried to find an image of an emergency department, and this is what came up. And I assume the guy on the floor is an Epistaxis patient who had tried to run away without being packed, because over half of our patients are still being packed. Around half our patients are being packed by the ED before they've even been got to us or been referred to us. So we really do need to engage with ED for any kind of further interventional study that we're doing. We can't just keep this within the ENT community because so much of the management has already taken place before they're referred to us. And in terms of dissolvable packs, we definitely saw a shift in practice there. Some kind of dissolvable product was only using 4.7% in 2016. So really it just wasn't, nobody was really declared as definitively managed with it. And rates were very low. And that compare that to over 60% usage if it was left up to us, and 30% of people, it was declared as a definitive management. So that's good. So our key points: incidence about the same. ED keep meddling with our patients and packing over half of them. We're using more dissolvables, and we're sending loads of people home, including people with packs in place. Right, tonsillitis and quinsys. What do we do with them? Right, so IV steroids were given to a lot of people. So again, talking even amongst the integrate group, whether this was something that was entirely common. It's been quite common in my practice, and I was involved in the MAC paper back in 2014. So we've sort of been advocating for giving steroids and trying to do outpatient management with these guys. But it was certainly something that we've seen now is relatively prevalent. So 2/3 of patients getting that. And actually, if you had you're suspicious of a quinsy, before you were given any IVs, we said that only 22% of people were able to swallow their medications or fluids in the ED, and that increased to 70%, 71% after they'd had the IVs, even within that 3 or 4 hour window within that ED timeframe. And looking at peritonsillar abscess, just another headline figure here, the guideline advice was not necessarily to drain them, and we found that about 1 in 4 patients wasn't drained. Other things that were in the guidelines weren't necessarily totally well adhered to. It said don't necessarily examine people's mouths, and we found that very hard not to do. As you can see, over 90% of our patients were examined, and we had pretty low rates of FNE. I don't know what that would be in your units, but around 10% of the tonsillitis, the quinsys were still scoped, and that probably represents some use in terms of diagnostics and things. So it's inevitable in that group. Okay, so let's have a little look at patient flow again. So we'll do this for tonsillitis first, and then we'll do it for quinsys. Reasonable chunk of our patients, so a reasonable proportion, are still being discharged. It's about half of them that these tonsillitis patients are. Let's ignore the admitted again, because we don't like them. But we can see that about 1 in 10 of our patients are representing even after they've been discharged. And if we look at it in terms of the representation status, and in terms of whether you had an IV steroid or didn't have an IV steroid, the rates were not too dissimilar, not statistically dissimilar at least. And let's have a look at our quinsy friends. Again, those we stratified them by being drained or not being drained. So that kind of 1 in 4 that weren't drained at the top there. We'll ignore our admitted guys. But again, it's about 10% of people that represented after that. But that representation rate amongst those two groups, again, not too dissimilar, whether you were or weren't drained. It didn't seem to affect whether you were likely to come back with a problem subsequently. So whatever management we did, whether we drained or not, it seemed to be pretty safe. So we didn't find any significant predictors, and that's despite pretty good numbers. So we had over 1,000 combined, over 400 quinsys and nearly 800 tonsillitis patients, but nothing was very significant in terms of predictors of the 10-day representation. And again, let's frame it a little bit differently and frame it in terms of those who are discharged from ED. So let's say about half of both of those groups are discharged from ED. Again, that's not randomized, that's not an interventional experimental study, but of those that were sent home, the representation rates for those was about 10% in both groups as well. But the overall admission rate, so again, this is all of the patients who've avoided that index admission, which previously would have been nigh on 100% for everyone. The subsequent admission rate with the whole group as the denominator is pretty low. So whatever we're doing with these guys, however we're selecting them, your judgment at the moment seems to be pretty safe in terms of keeping these guys out of hospital and not having to admit them at any point. And that's just the admission cohort, just for comparison. So if you've been admitted once, you're actually more likely to also be readmitted again. Okay, so final points just on the discussions there. What about the numbers? Well, in 2014, we had 3 quinsies per centre per month. In 2020, we had 4 combined tonsillitis or quinsies per centre per month. It's only about a quarter of those cases were, it was only about 1 in 3 with PTA. So numbers certainly seem to be lower, and that may have been because of social distancing and behavioural change in society with COVID. It may have been that there was some aversion to hospital, but we also had reduced admissions of those who did present. In 2014, it was much more standard practice to admit people after they've had their, even if they had their meds down in ED, with 8% only sent home from ED. Whereas we had around 50% of both of those cohorts were discharged in 2020. Some of that's because, well, actually it's much easier to discharge these guys. You're not worried about them being old crumblies. They won't have the social issues that you'll have for the Epistaxis patients. So this is the age spread amongst our tonsillitis, peritonsillar abscess patients. You see, obviously, it's heavily weighted towards those younger COVID spreading people. Yeah, patient preference may be higher to avoid hospital, and they may have that as an option if they're not so old and crumbly with other comorbidities. And we also really felt that steroids seemed to be safe to use. There weren't any reports of any adverse events, and they probably do facilitate discharge as well if we're moving from a quarter to 3/4 of patients able to swallow after being given the IV steroid and the IV antibiotic ED. So incidence is lower. We're giving steroids to loads of people. We're getting half of people away from hospital, and it doesn't seem to be a problem. We're not draining a quarter of them. It doesn't seem to be a problem. However, we're selecting those patients. Some people seem to be able to avoid that, and Matt might touch on some of the evidence for that in a moment. And there didn't seem to be any significant predictors of who we should or shouldn't be sending home, if that was going to be useful. Right, so Matt, I'll hand back over to you now.
Thank you. Right, thanks, John. So, what are the good and bad bits of what we've done? Well, the strengths are we managed to capture the peak and capture the point at which a lot of the changes were made. If you look at the date that the guidelines were issued, it's a few days before we managed to actually launch the project. So we managed to get a prospective data set. It helps with the completeness of the data and the quality of the data. This is a large study, and I'll put it in context later with what's been published elsewhere. And it's got national coverage, so it's very widely applicable. We know that this isn't just 1 or 2 tertiary referral centres, this is what's happening across the UK. We've had very high data field completeness, and the interim and final reports, I think, are a real strength of this. So if you look at the table on the right, we managed to roll this out for no money, having been very pleased about several £1,000s for other audits. But the time to dissemination here is key, and that's because this was really considered at the start a patient safety issue. This was in place of that monthly M&M that you do, that monthly clinical governance meeting, and we were able to get out reports within a few days of having the data. So it was synchronous data collection and reporting. Well, the weaknesses, well, this is an audit stroke observational study, as John says. We don't know a lot of the detail as to how patients were selected, and I'll come on to that. Bleeding severity has been this Achilles heel of Epistaxis work, and we had problems with it in 2016, and it's very difficult to quantify, and we know that in the patients who are admitted, there'll be a more severe Epistaxis cohort. Classification of patients is another potential weakness. We simply relied on individual site doctors to say whether they thought the patient had a tonsillitis or a quinsy. And we've all been wrong. We've all had those dry taps or been surprised when a patient had a quinsy. But given that 9 out of 10 patients had their throat examined, I think this probably represents a pretty fair judgment as to whether the patient had tonsillitis or a quinsy. We didn't collect data on physiological parameters, any laboratory tests, imaging, comorbidities, more so for tonsillitis, we did for Epistaxis. And the reason being because it's just data overload. Some of that would have been useful. It would have been helpful if we were trying to make a calculator for risk, for example, or trying to work out exactly what the decision-making process was, but it would just be too much, and particularly at a time when everyone's under a bit of stress and working under difficult circumstances. We recorded brief presentations over 10 days, the reason for 10 days being that we could feed back data much quicker than we using a 30-day marker like we did for our previous projects, but that could potentially miss a few late presentations. And we also didn't look at GP records, notoriously difficult to do. And there could have been things that went back to GPs that we missed that happened, but probably not major complications. And the same goes for hospital avoidance. We've all heard about patients ignoring cardiac chest pain and not turning up to hospital. I'm sure if they had a slight problem following a quinsy drainage, they may not have turned up. But we probably didn't miss the big complications here. We didn't miss any of the things we really need to know about. So what else has been reported? Well, when you consider the sample size for our work, there's reassuringly, or perhaps not, there's not much else out there. Probably the best piece of work comes from the UK. It's from Hussein et al. It's done in Leicester with Prof. Ray. They tested every single epistaxis patient they had in a consecutive group. So they had 40 patients, and they found that 15% of them were COVID positive, which was a bit worrying. And at the time, I spoke to Prof. Ray on Zoom, and we were finding quite high rates as well, as you saw from John's talk at the start of testing, at the start of the peak, when there weren't very many tests happening. But actually, as things have gone on, we found that hasn't really stood up, and we haven't seen high rates of COVID. It's not that there's inflammation within the nose and it's causing lots of epistaxis. So we don't think that epistaxis is a presenting symptom of COVID, at least not to a useful clinical level. There's a French paper which was retrospective, which specifically took those patients who had COVID anosmia on the theory that perhaps these guys have inflammation within the nose and have epistaxis because of that. They found an 11% rate of epistaxis in that cohort. They don't quantify quite how severe or what they do with them, but it's interesting to see that there's a relatively high rate in that group, although we now know that the anosmia may not be simply inflammation. An Italian group looked at HDU patients. They had 100 patients admitted to HDU and found that 30% of them also had epistaxis. But of course, some of them are anticoagulated, some of them are having NG tubes put in. Probably not very helpful in our clinical decision making. And I've put in there a case series from the US. It's got 4 patients in it. And that just gives some context. It's published in a good journal as to perhaps how helpful and how different our work is to what else has been published around the world. And there's a guideline from Italy that's come across. It's a well put together, but it's expert opinion guideline, which suggests careful PPE, not using sprays in the nose, and using dissolvable products. It's much in line with the ENT UK work, and I've not found anything that's better than the ENT UK guidelines for epistaxis. What about tonsillitis and quinsies? Well, there's a published case report with 1 case in the US with a quinsy and COVID, recommending conservative management. So again, there's not much else out there. There's something quite interesting we came across, which is the Liverpool peritonsillar abscess score. Some of you may have seen this before on ENTSHO. Andy Lau and group were originally developed it before COVID came along with the idea of triaging these patients. And they've taken out the throat examinations, so now this is a way of triaging patients without having to look in their throat, which seems very useful, and there's some good values for negative predictive value and positive predictive value given there. I have to say it's not tested in COVID patients, and it is a rather small sample. 100 patients is quite small for making that sort of calculator. And then finally, there's a guideline published from the US. Again, this is a sort of expert opinion of multiple experts from the US, China and other countries, and they suggest antibiotic management, needle drainage for quinsies, again to reduce the exposure to aerosols and to reduce the need for drainage, open drainage. So there's not much else out there in terms of guidelines or evidence. So how should we be managing epistaxis? And how should we be managing epistaxis past COVID? That's the important question. We are perhaps going into a more active period now, but coming out of that, how is this data helpful to us? How have we learned from COVID? Well, what we know is that our practices are safe and they're effective. And as John's described, the problem with an audit or this kind of work is you don't know exactly how that decision was making happened. It's not randomizing one intervention to another and making sure everything's matched. This is very complex. Patients being assessed by a clinician who uses guidelines, all sorts of parameters, their clinical examination, and possibly years or decades of experience to try and judge what to do. However, taking all that into account, what we have shown is that dissolvable packs are practical. They're possible. When you can put them in, they're safe, they're effective. Patients can go home and they don't come back more often than other patients. And that's in line with the British Rhinological Society guidelines. Those are guidelines that we developed and integrate through 7 different systematic reviews and a consensus group. And in line with that, there seems to be a role for IV tranexamic acid. I don't think John mentioned it, but actually the tranexamic acid patients did better. And in the original work we did, they did slightly worse. So perhaps as it's becoming more used, it's being more used for an appropriate group. And what we hadn't really looked at before with the BRS guidelines, at least not to any great extent, is the role for outpatient management and the benefits that has for the NHS and patients. And I think we've shown that we can send patients who've got dissolvable packs home, and we can send home probably a third, who knows how many more patients could go home with a dissolvable pack safely. And that brings benefits to the NHS. It means we're not using up beds, and that's good, whether it's COVID or a simply winter bed crisis. And it's good for patients because they don't like being in hospital. What doesn't it answer? Well, it doesn't answer the role for cautery, and that's because the COVID guidelines don't recommend you cauterize, and it's probably not the time to be training people to examine the nose and prepare it and cauterize. But cautery, in our previous work, has been recommended as first-line treatment in the BRS guidelines. And in our rhinology paper, where we did some statistics on the 2016 data, you can see the Kaplan-Meier curve on the right side of the screen there at the bottom. And when the patients were managed in a compliant manner with the guidance, that is examination of the nose, cautery, and avoidance of pack if you can send them home after cautery, then they had a very short hemostasis time, even if they then ended up packed after the cautery failed. Whereas if you didn't follow that and you just packed them and put them on a ward for 24 hours, which is what we found happens, then you have much longer hemostasis time, which is what you'd expect. So cautery, I think, is important, but this work hasn't really touched on that at all. And pack avoidance. So as John says, we found in previous work that packs are painful, patients don't want them, and they'll go to any measure, even staying in hospital at night, to avoid that small chance of having a pack put back in. But half of the patients came to us packed from ED, and that was the same in 2016, it's the same now. And we need to overcome this. Patients don't want the packs out, we need to avoid the packs going in the first place. And that's going to take a lot of work, and it's something I've been doing locally where I work, and I'm sure other people have been doing it as well, but it takes a lot of effort to try and work with A&E, and there's a lot of practicalities. They're very busy, we're very busy too. So what about tonsillitis and quinsies? Well, again, we've shown that new practices are effective and they're safe, and that's a very complex thing, but nonetheless what we're doing is working, and that's using the guidelines and using our own experience. What we can show through the numbers is that IV steroids and antibiotics facilitate discharge. So they turn patients you can't swallow into patients you can swallow in a matter of a few hours. And you think, well, do they bounce back then because their steroids have worn off? Well, no, they don't actually. So you can send these patients home just by giving them steroids and antibiotics, and it saves a night in hospital at least. And that's been shown without much data in 2 previous reviews for each of the conditions. What I think is a bit of an omission in the Epistaxis guidelines is a review of the physiological status of the patient. Doesn't say anything about using heart rate or blood pressure or any other marker that might be used for sepsis as a marker of whether you can send the patient home. It simply goes on whether they can swallow or not. And if you look at pretty much every other guideline that's been generated, they all have physiological markers of sepsis as a criteria in the absence of for going home. So I think that probably needs to be included. We can't really comment on our own data for that because we didn't collect all those figures. What we did show again is that outpatient management is suitable. Patients can go home, they don't come back, and patients who have quinsies can have them drained and sent home, or even not drained and sent home, and they don't seem to come back with problems. If they do come back, they don't seem to be admitted. They continue that outpatient trajectory. So what doesn't this answer? Well, there's the role of clinical examination. The reason we don't know that is because 9 out of 10 patients were examined. So we don't know from that small number who weren't. It starts to get very small when you start to analyse these things. So do they do worse than the others? We don't know. What's the role of quinsy drainage? Now, I think most of us, if we thought there was a quinsy, would drain it, and in line with guidelines and in line with perhaps what was thought best during the height of the pandemic, these quinsies weren't drained. Now, interestingly, there's a paper that's just being published at the moment, which is looking at medical intervention versus surgical drainage of quinsies. And that shows, even including a randomized controlled trial, that there's no difference in outcomes between treating a quinsy medically versus treating one surgically. So, perhaps this does actually tell us something about whether we should be draining all these quinsies. Are we doing some harm? We don't really have any significant idea of whether that's happening. If you start to say, well, we don't drain quinsies, then do you examine the throat? There is a risk you could miss something like a supraglottitis, but if you start to analyze the figures on these things, even in big data sets, you start to show that some of the things that were accepted knowledge are not necessarily essential. So that's an overview of the Epistaxis and the quinsy data. It gives you an idea of what everyone else around the world is doing, and it shows you what a research collaborative can do. And if you want to get involved, we've got the National Mastoiditis Audit, which is run with the BSO and BAPO, which is launching in November 2020, and we've got all the details on the website for that. And there's also an opportunity to join Integrate, because we've got 4 or 3 subcommittees and a main committee. We've got a lot of people who are coming to the end of their 2-year terms, and we'd really like to have some new trainees join us, particularly some more junior trainees who want to work their way up and gain some new skills. So again, go to the website, or you can email us using the details here. And very importantly, we want to thank everyone who submitted data for this and did a lot of the hard work at the local sites. So thank you.
Thanks, Matt. And to John, that was a great presentation. We've got a number of questions, actually. I mean, first of all, I want to commend you both for putting this together. I mean, to turn around such a large study in such a short time frame and for it to be so successful is no mean feat. And compared to, obviously, you've shown the data from very small numbers where, to be honest, we can't, from other studies, of course, where we really can't conclude anything. So I do commend you. So first of all, if I can start with a technical question, and perhaps, John, I could ask this to you. There's a question about how you got the ED data. Was it collected by the ED staff, or was it collected by the ENT staff looking at the ED data?
Yeah, no, it was all as entered by the ENT guys that were the site leads for the study. So it was asked what was the status of the patient before they were referred to ENT, and then what was your intervention afterwards, and then we're able to discern as well what their status was at admission. Yeah. Okay.
Great. And Matt, if I can ask you the next one, which was around the role of steroids. I think you've looked at probably a number of variables, and of course, as you and I and everybody knows, once you do too many analyses, you may have small numbers. But one of the questions was about the role of steroids. Did you find any difference in sort of any of your outcomes, either for tonsillitis or epistaxis, with steroids? Because there was a policy initially of not giving steroids, then giving steroids. I mean, perhaps you already mentioned that in your talk, but that was one of our questions about whether there's any evidence of difference in outcomes from the use of steroids.
Yeah. So, I mean, the big difference, dramatic difference is in terms of the patients who could go home. What we didn't find is that use of steroids or not using steroids predicted recurrence. So the patients, we did statistics for that, and actually, because a lot of people had steroids, you could get reasonable numbers. The risk of COVID from steroids, however, is a complete unknown, and that's what you allude to with should we be using steroids? We don't know that, and I'm not aware of any other data that has been published to say whether that's a particular risk. But what we did see very clearly is that converts patients from not suitable to discharge to suitable for discharge without any apparent adverse effect on representation.
Sure. No, that's actually very useful, and I think many of us would give steroids. obviously this is not a randomized trial that you did, but I think nevertheless the evidence do support that idea. Okay. So some other questions. Sorry. Perhaps I can direct this to you, John, and I don't know if you can answer this because it's not directly related to the study, but there's a question of whether you think packing counts as an aerosol generating procedure. And I mean, what do you think about that? Do you think that that's why dissolvable packing is recommended, or is it just to avoid admission? I don't know if you're able to comment on that.
Yeah, well, I don't know. I mean, putting packs in noses is not a pleasant experience. We worry about F&E because we say the patient might sneeze on us or something, and that might generate some aerosols. But I think it's more likely that your epistaxis patient is going to scream at you. And Declan Costello's work shows that the higher the volume of the singing, if you call it a type of singing, the more likely you are to be aerosol generating from that. So I think I don't think the kind of activity of putting something in the nose is necessarily going to be aerosol generating, but if they scream in your face, then it might be. But equally, we've shown that at the moment the prevalence is very low. These aren't a higher risk group of people either that we think from the data that we've collected. When you look at it in terms of a population and then who presents with epistaxis and then who of those are going to be COVID positive, it doesn't seem to be very high, and it shouldn't be something that we necessarily should be worried about. If you look at it the other way around, which some of the other studies have done, which is if you present with epistaxis and then looking at the rates within that, I think it might be a little bit different. But I would say that I wouldn't be worrying about it. I mean, I think at the moment everyone's going to be saying do everything in full PPE anyway, but it's likely that wearing eye protection is sensible anyway. I've certainly had spatters on goggles just from managing a normal epistaxis case, and probably a normal fluid face mask is going to be sufficient. I don't know, Matt, do you have any opinion on that?
We don't know.
No. Do your patients scream as well, or is that just me?
Well, as we all know, ENT anecdotally seems to be a higher risk specialty, and I think I'd agree we don't know. We're probably not a lot of aerosol being generated by nasal packing, but we don't know. We do know that those who've got COVID, the highest sort of carriage is within the nasal cavity. So, you know, if you've got an asymptomatic patient, it may be reasonable high risk, but it may be just simply because ENT gets so close to the face with what we're doing, which is obviously going to put you at increased risk. So
I think it's much more likely you'll touch some saliva or some nasal mucus, or maybe even blood from the nose. I think the rates are quite low transition from that, but it's more likely that than it is from the actual aerosol generating aspect of it. That's my impression.
Sure. Okay. So another question: Do you have any sense of what's happening now? Have people changed their practice and continued with this practice, either in the emergency department or in ENT? You've certainly shown that. Do you think more and more people are changing practice, or perhaps you haven't got those data?
No, we didn't really dissect it too much in terms of what was going on within each of the periods, because there wasn't actually too much change. We had sort of a few more consultants in the early days that were sort of packing noses and things, and then that kind of tailed off as practice went back to normal. But there was no significant change in anything we looked at in terms of between the 3 audit periods, so we didn't include that in any of our analysis. We know that from the parallel study that Integrate are involved in looking at the 2-week wait telephone triage, that practice has flipped back. So lots of places that were doing purely face-to-face appointments for that first consultation are going back now to doing face-to-face appointments. But I don't think we have no handle on it after what happened at the end of June, really.
Sure. No, I understand that. And Matt, you did touch on the idea of not draining quinsies, which I have to say sounds very odd to many of us. You know, I think I was told never let the sun set on an abscess. But you're suggesting there are data out there. I mean, I don't know what this is another question. What are your personal views on the idea of not draining a quinsy?
So I personally, I would always drain a quinsy, and I would always recommend an SHO drains a quinsy. But you know, we have to be evidence-based to an extent, and you know, there is a degree of evidence to show that there's no difference. Now that might just be we don't have enough evidence, but I think until you show that there's some harm from doing the drainage, I think most of us are going to carry on doing it.
Yeah, I would say I tend to agree because of the risk of it also developing into a parapharyngeal abscess, which obviously can potentially be much more serious. So risk versus benefit, I agree with you. So I think we're getting towards the end of our time, and